university hospitals. And let me get my screen share up here. Oh, it's not working too well. Hang on. Oh, it's saving it. Just saved it. Okay. Now I can go back. Okay. Love it. There we go.
I like hearing your self-talk there, Chris.
Sorry, I was just like, well, no, I was making some updates and couldn't get it to work. So that's all right. I've told you the story, but now I got a picture to go with the story, so it's pretty cool. With permission, of course. Okay. So again, welcome to those of you who haven't been to the Echo before, and hello to my old friends and buddies that I see every week. So today we're just going to talk about, and I hope, tell me if my sound is okay, because every so often, depending on my positioning, nobody can hear me. Today we're going to talk about common patient and family objections to MOUD and talk about some strategies to increase patient and family acceptance of this as an actual treatment option. So as we go along, I just want you to recall, maybe yesterday or last week, the last time that a patient or family member expressed an objection to Suboxone or Vivitrol or methadone, and just try to recall exactly what that person said, and then think about what was your actual response. And if you were happy with your response, fantastic. And if you kind of weren't sure what to say, then hopefully after listening to today's talk, you could come up with a different response. So that's what I want you to be thinking about. So these are the things that I've heard, and perhaps you've heard variations on the theme. So sometimes my patients or family members will say, hey, this is terrible. I went from being addicted to heroin and now I'm addicted to Suboxone. People, unfortunately, in 12-step programs will sometimes tell my patients, hey, that's just a crutch. You're not really in recovery. And hey, your sober date really isn't your sober date as long as you're taking Suboxone. And, you know, you're not in real recovery. So things like that, very, I call them rude and demeaning things. Sometimes my patients will say, I really hate depending on this. This is, you know, I want to be weaned off as soon as possible. You know, they'll get 2 months of sobriety under their belt and suddenly, like, you know, they're on the pink cloud, everything's perfect. And they're like, okay, get me off of this medicine. And I just have to sort of say, okay, whoa, Nellie, you know, like slow down. Part of the reason that you're doing so well is because you're on this medication. The patients themselves will internalize a lot of the stigma and say, yeah, I truly believe that if I'm on this medicine, I'm not actually sober, I'm not actually in recovery. And then just sort of that whole thing about people say I should get off of this medicine. So in fact, oh, what was my good one this week was one of my patients, the pharmacist literally questioned him this past month, like, how long are you going to be on that stuff? I was like, okay, you know, number one, as the pharmacist, not sure that that's any of your business. And number two, you know, did you have to be that rude? You know, how long are you going to be on that stuff? Like, you know, if I went to the you know, store to pick up my medicine and somebody said, hey, how long are you going to be taking that? You know, like totally rude. Like, what does it matter to you? Please just fill my prescription. So yeah, that's what happened this week. Yeah, that got me fired up. Something always gets me fired up every week. So so some of the underlying themes and causes, obviously, are stigma, the guilt and shame of having the disease of addiction and being in recovery. Like you could feel guilty and shameful even about being in recovery, and just a lot of misunderstanding still and misinformation about this disease. So I'll talk a little bit in generic terms about health-related stigma, and then we'll get more specific. So health-related stigma is a socio-cultural process in which social groups are devalued, rejected, and excluded on the basis of a so-called socially discredited health condition. And boy, if I ever heard of a socially discredited health condition, addiction surely is it. And so that's a term that was coined by Livingston about 10 years ago. And stigma can come on 3 different levels. So there is the intrapersonal stigma, which is sort of the the beating up that we do of ourselves. There's the interpersonal stigma, like what my pharmacist said to what the pharmacist said to my patient this past week. And then there's the institutional stigma, which is the way that systems are set up to potentially, stigmatize people with particular health conditions. And so here's an example from an institute that works, I think, almost exclusively on stigma, or stigma is one of their primary things that they work on. It's called the Danya Institute or the Danya Institute. I really don't know how to pronounce it, but they did some interviews. And so this was years ago, and they did some interviews. And so this is one of the quotes, which again, really kind of got me like right in the chest, right? So this lady said, "It's not the belief of others, it's the stigma within that affects me the greatest. It is the deeply rooted disdain that seems to be threaded within the fabric of my being that stagnates my progress. It reveals its ugly face when I perceive that what I have to offer is not substantial. It's the belief that I'm not worthy or good enough. It's the belief that I don't have what it takes to make it." So imagine, right? Like, here's a person that, presumably is, trying to get her life back on track, and she's kind of her own worst enemy. So that's internalized stigma. So there's another project that's called the Anti-Stigma Project. And so there's a link there. And here's another, I think this was a gentleman. And so he was talking about, what it's like to come forward and sort of say, I have a diagnosis. So this poor gentleman, and this is nothing new. This happens every single day in our country. You finally decide to get help, and then you're punished for it, pigeonholed into a diagnosis, shamed, labeled, and discriminated against for life. The stigma can be worse than the illness. And so we wonder why our patients don't want to tell their healthcare providers that they've been in recovery for 5 years, because suddenly that gets written down into the chart, and it doesn't get written down as, hey, in stable, sober recovery for 5 years. It gets written down into the chart as alcoholic or, opiate use disorder. And that's all that is seen on the problem list. So then when they go to the hospital for something else forever, there'll be the diagnosis of, opiate use disorder or this or that. And so, yeah, patients get really sensitive about things like that. I guess I would too. So that's part of interpersonal stigma, or stigma between individuals and people. And then finally, there is structural stigma. And for healthcare providers specifically, and this has been studied extensively by Livingston, healthcare providers often hold negative beliefs about people with substance use disorders, which then contributes to not treating people very well. So here are some of the negative beliefs that they hold, so-called stereotypes, right? And we can talk about the fact that, stereotypes are there for a reason, blah, blah, blah. Okay, fine. But when you then start to sort of label entire swaths of people in a particular way, that's not a good thing. So in general, some of the beliefs are people abuse the system because they're drug seeking. They're just trying to divert drugs. They don't care about their health. They waste resources, and they don't do anything you tell them to do. I mean, have those things been true for my patients at some point in their life? Absolutely. Is it true of every person every time that has a substance use disorder? Absolutely not, right? So then what happens is, because of structural stigma, certain places, healthcare places, or even counties. I have a favorite story about one of the counties in Ohio, which shall remain unnamed. Maybe one of you lives in that county. They may refuse to offer certain services, or they might not prescribe effective treatments. So somebody has chronic pain, but they've got that big label of opiate use disorder. So therefore, no pain doctor will touch them, and nobody cares to listen to their story because they've already been pigeonholed as they're a drug seeker. I don't care if they have chronic pain, they can take Tylenol. What is that? So crazy stuff. But one of the stories, this was literally 2 years ago, which is shocking / not shocking because we live in Ohio. But basically, there was a county in Ohio that passed an ordinance that said that we are not going to support needle exchange in this county. And in fact, if I have it correctly, the people that brought this forward was the health department. So I'm like, dude, if your own health department in your county, right, in the state that has the third highest overdose death rate from opioids, says that we're not going to support needle exchange. I mean, what chance do we have? Like, seriously? So I don't know if that ordinance is still on the books, but it's probably something worth looking up today. But that was driving me crazy when I heard about that. So yeah, so I like to look at the news and see what's what. And when I hear stories like that, I like to share them because I hope to get people hepped up as well and, maybe want to do something about it. All right. So what happens because of these three types of stigma? Well, first of all, the public sort of looks at the stories, right? Remember the picture of the mom and dad that were overdosed in the front seat? There was like a 2-year-old child in the back seat, right? Like those are the pictures that make the news. So people see those pictures and they go, these people are worthless. I don't want to pay for this. So then that decreases access to resources, treatment, and social services. At the same time, the internal stigma and seeing pictures like that on the internet is going to stop the people that have the disease from getting help, because I don't want to tell anybody I have that, because I'm afraid that I will not get treated with respect or dignity in the treatment system. And a lot of times they're not wrong. So again, we are like systematically depriving people of dignity, and we are just blocking them from full participation in society. I mean, again, if you want to talk about issues that really will take all of us to change, it's the drug use disorders are criminalized, and then you get something on your record and now you can't get it off your record because it's 2 felonies, and they're going to be with you always, which means guess what? You can't get housing, you can't get a job. So what is it that you're supposed to do as you try to, quote, get your life back together? I mean, real problems every day, right? So if you can't live somewhere safe, you can't work a job that pays a decent wage, what's left for you, right? So it doesn't matter if I'm giving you Suboxone. It doesn't matter if you've been sober for 4 years if you can't get yourself back into society, because the structure is set up so that you can't do it. I mean, again, talk about social justice. Anywho, is there something you can do? Yes, you can absolutely do the things on this slide, and I'm sure many of you have your own ideas of what you can do, and better yet, what you already have done to help your patients that are in these situations. I would encourage you to get curious, find out more. So when a patient says something like, oh God, I don't know if I should be on the Suboxone stuff anymore, or Doc, can you just take me off of this stuff? This is terrible. And you're sitting there, well, what do you mean it's terrible? What's going on? So what are the concerns? If the family is really on them, invite that family in. They're like, I've been called a drug pusher and a drug dealer by people that don't know me because I prescribe Suboxone. And so I say, hey, if that's what your mom thinks, bring your mom to the next appointment. She can meet me. She can see I'm not a monster, not a drug dealer. Like, I work in an office, right? I legit have like a diploma hanging on the wall. She can talk to me, share testimonials. One of my favorite testimonials is called In My Own Words. It's like a 17-page document. It was actually a contest, an anti-stigma contest, where they invited people to talk about their experiences of being on Suboxone, being on methadone, being on Vivitrol. And then they had a contest, and then there was a contest winner and, honorable mentions. And then they published the best stories in this little pamphlet that you can get. I mean, I think we have it on our website, I'm pretty sure. And then there's like 1-pagers, which you can use as education. So I will often pass these out to my patients and say, hey, just kind of casually leave this on the dining room table at home, or, and leave it somewhere where your family member will find it, if they are afraid to sort of bring up the topic. So basically things that challenge the myths about, if you're on this medicine, you're addicted to it, blah, 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 those type of things. And so in sort of a scientific way with references, these myths are sort of dismantled. Again, I read it a lot. Oh yeah, education is the answer to stigma. And it's like, education can only go so far. I mean, when you're talking about changing hearts and minds, when you're changing hearts and minds, it's one-to-one, it's witnessing, it's testimonials, it's a lot. It's not as simple as, okay, read this pamphlet and suddenly you are not going to stigmatize people anymore. I wish, but no, it's way deeper than that. The roots are way deeper. So I think it's important for us to constantly challenge internalized stigma when we hear it from our patients, these are some of my favorite things to say that I've learned over the years. You deserve better. You deserve recovery. Hey, by the way, it's okay to take medicine that keeps you alive and not using. That's cool. Hey, you don't need to be a hero. You don't have anything to prove to anybody. Okay, everybody's got something. We all need help, right? Nobody's perfect, that kind of stuff. Again, you're worthy of help. Your life is worthwhile. So this is nothing to be ashamed of. So call it out. Like, don't just leave it sit there, right? To fester, call it out. So I like to end this presentation with one of my favorite stories from my patient. And he brought me some artwork. This was September of 2018. I had known him for about a year at that point. And so he made this, and he calls it Breaking the Chains of Addiction. So, and he made it out of his Suboxone wrappers. So this is a guy that's been on Suboxone since 2013. He has saved every single Suboxone wrapper that he has ever taken in his life. And he says it is a reminder to him of how far he's come, and that that he needs this medicine to stay alive. So this is what I was updating. So these are his own words. Obviously, I have his permission to share, and I also have his permission to share his picture, which I'll show you. So the artist said, what Suboxone has meant to me is that addiction had me handcuffed, and Suboxone allowed me to break the chains of addiction. Once the drug stopped, I had to, quote, do what they told me to do, unquote, at 12-step meetings. I did 90 meetings in 90 days, twice. Sense a theme of, like, you know, OCD here, or OCPD. Right now, I am attending Suboxone-friendly 12-step meetings. Suboxone alone does not keep me clean, but gives me a better chance at recovery, along with meetings and staying busy. Medication is a great tool in my arsenal. The medication is a safety net, and it's amazing. So he said all this stuff. I never taught him any of this stuff. It was probably Dr. Elhaj, the guy that had him for 4 years before me, that taught him all this stuff. But he was like a commercial or something. It's like, this is fantastic. So this is my update. So many of you have heard this story before, but I was just wanting to update you. So this is a guy who's 31 years old. He's had opiate use disorder since he was 21. His current dose of Suboxone is 6 milligrams a day. He's been continuously sober, so no relapses since February of 2013. He also quit smoking in 2013. He works out regularly. He does have a history of depression and anxiety, and he's been on Buspar and bupropion for a long time, so I've continued those. And he hasn't been psychiatrically hospitalized in over 9 years. Socially, this is a guy that went from selling Xanax to get pain pills, and a guy that liked to, in addition to his pain pills, use cocaine and marijuana, to when I met him in September of 2017, at that point, he was already a full-time computer programmer at a Fortune 500 company. And just recently, within the last 6 months, he now got a higher paying job and, you know, better benefits, although he already had great benefits, better benefits, because he now works at the Federal Reserve Bank in Cleveland. So just imagine going from selling Xanax to being trusted to have high security clearance at the Federal Reserve Bank. I love that. And he's now 4 classes away from his bachelor's degree in computer science. And so I have seen him, since he's been super duper stable and sober, I've seen him 16 times, or approximately 4 times a year, since September of 2017. I was looking at my notes this morning, and I last saw him on March 4th. So I just saw him last week. And what did we talk about? He was talking about, you know, doc, I think now, finally, 8 years later, I might be ready to move from buprenorphine 6 to buprenorphine 4. I said, go for it. You know, like, let's try it, see how it works. And I said, look, I'll give you the 6s. I'll keep you on 6. You try to get down to 4. If you're not comfy on 4, go back up to 6. No harm, no foul. So he's going to try that out, and I'm going to see him again in probably 3 months. The other thing he was talking about was that he's actually redoing his 4th step. Imagine a dude that's been sober for 8 years is still looking at his life and saying, you know, I want to redo my 4th step with my sponsor. I was like, are you for real, man? So my favorite story about him is that in the depths of his addiction, he had this wonderful blue, gorgeous BMW. And he said to himself, you know what? I am going to get that car back. It took them about, this was September, this picture was taken in September of 2019. So 2 years ago, after a 7-year journey, he actually was able to get this car. I don't know if he had enough money to pay cash for it, but it was some extraordinary story. And I was so taken aback that he was telling me about the car, and he was telling me how he lost the car, and he always, when he got sober and got to the point of having enough money, he was going to get his damn car back. And I said, for real? I said, can I go see the car? So we walked over in the parking deck together. So I walked him out of the building, and I said, can I take your picture in front of the car? And he said, yeah. And so maybe 6 or 7 months ago, I said, would you mind if I shared your picture? Absolutely not. Please share my picture, share my story. So this is the guy. And so I just look at this, look at the grin on his face. There's nothing you know, I cannot describe that. You have to see it. And look at the gorgeous car. I mean, I'll never own a car like that. That's a blue Beamer. I mean, it's gorgeous. So anywho, let's go back to the questions that I asked you to think about. When was the last time that somebody said, this is terrible, this is a crutch, I'm still addicted, and what did you say, and what might you say differently? So I put tons of resources on here about the things I've told you about. We'll make sure to get all that stuff up for you guys on the website. And that's the end of my little share here. Stop sharing, and we'll get back to